Hello, thank you so much for joining the Focus Certification Academy for today's Focus Bites webinar. My name is Daria, and I'm the Global Learning Program Manager with Focus Certification Academy, and I'll be your webinar host today. The webinar is now beginning, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you may have throughout the webinar. The presentation will include a PowerPoint presentation and the time for questions and answers at the end. Today's topic is sonographic imaging of musculoskeletal bursae, and our speaker is Dr. Raffi Salibian. Dr. Salibian is a radiologist with fellowship training in MSK imaging. Dr. Salibian is actively involved in focus training with a special interest in MSK ultrasound. He's also a member of our focus education committee. Welcome, Dr. Salibian. Thank you so much for joining us today.
Great. Here we go. Good morning or afternoon, everybody, depending on where you are. My name is Raffi. I'll be talking to you, as Daria mentioned, about sonographic imaging of various bursae that we see throughout the body. Let's get started. So here is a list of many of the bursae that we commonly encounter that can present pathologically as pain and inflammation. We'll be talking about from the shoulder down to the ankle. This slide, I think, is really important to sort of set the stage for how important knowledge of anatomy is when evaluating these musculoskeletal bursae. You see here 4 different examples of bursae from everywhere from the shoulder to the knee to the hip. Some of these inflamed bursae look very solid sonographically. As you can see in these 2 examples, some of them look more simple and cystic. And so one of the important teaching points when evaluating these bursae is that you can't really rely on the intrinsic sonographic appearance of these structures. You have to rely more on their anatomic location. And that's why an understanding of where these bursae belong anatomically is critical in making the diagnosis. And so I'm going to do my best, especially coming from the point of view of a radiologist, to show you anatomy in the context of different imaging modalities. I'll try to show you where these bursae are located radiographically, on CT, on MRI. Those imaging modalities are a little bit easier to establish the anatomic boundaries than the focused ultrasound imaging. And then, of course, we'll always come back to ultrasound to reinforce the ideas. But anatomy is going to be key when making the correct diagnosis of bursal inflammation. So let's get started with the lower extremity, and then we'll jump to the upper extremity. In the knee, there are several different bursae that we see frequently. Anteriorly, I'm going to talk to you and show you lots of fun pictures of bursae that get inflamed in the anterior aspect of the knee. Here, for example, is a very nice radiographic representation of prepatellar bursitis with significant prepatellar soft tissue swelling. There is a bursa deep to the medial collateral ligament that can be inflamed. Inferiorly and anteromedially, we are all familiar with the inflammation of the pes anserine bursa that can cause symptoms in the knee area. And probably the most famous of knee region bursae that can cause us problems is the Baker cyst, located in the posteromedial aspect of the knee. And so, let's talk about this most commonly encountered knee region bursa, the Baker cyst, aka the popliteal cyst. And when we talk about a Baker cyst or popliteal cyst, what we're saying more technically is that this specific bursa, the semimembranosus gastrocnemius bursa, is inflamed. So anatomically, again, very important, we need to recognize that the semimembranosus gastrocnemius bursa is located in the posteromedial aspect of the knee. And more specifically, the semimembranosus gastrocnemius bursa, or recess, is located between 2 tendons, the medial head of the gastrocnemius and the semimembranosus. The mnemonic that we use to teach our residents and fellows for identifying correctly the location of a Baker cyst is that bakers make M&Ms, hence the little reminder here with the M&Ms. So bakers make M&Ms. We're looking for a cyst, an inflamed bursa tracking between these two specific tendons, the semimembranosus and the medial head of the gastrocnemius in the posteromedial aspect of the knee. Certainly, this bursa can be primarily inflamed due to involvement by a primary synovial pathologic process like rheumatoid arthritis or gout, but more commonly, a popliteal cyst or a Baker cyst is due to primary knee pathology. Osteoarthritis, rheumatoid arthritis occurring intra-articularly within the knee causes inflammation, causes fluid buildup, which then decompresses posteriorly into the Baker's cyst. Why is it so important to recognize the anatomy of a Baker cyst before identifying it as such? Well, it's because we are all commonly identifying these posterior knee masses, and we're so quick to characterize them as Baker cysts. And while most of them are Baker cysts, we need to be cognizant of the fact that aneurysms, soft tissue sarcomas, and hematomas in the context of trauma can also present as posterior knee masses. And so, let's start high level and drill down to the ultrasound. I want to make sure that we're all oriented appropriately anatomically. Here's a radiograph, just sort of pointing our eye to the back of the knee where we would expect a Baker cyst to be. Of course, we're not going to see it well radiographically. The MRI is very helpful in orienting us. Notice where we are, posterior and medial. And I've highlighted for you as well, labeled for you, the two tendons. Bakers make M&Ms. We have here the medial head of the gastrocnemius muscle. We have here the semimembranosus. These are the two hypointense round structures between which we have a cystic mass, the Baker cyst, the popliteal cyst. Here we have a nice example of distension of our semimembranosus gastrocnemius bursa in the posteromedial aspect of the knee. And now we get a chance to look at what the Baker cyst appears like sonographically. Again, notice medial is here, lateral is here. These tendons, slightly more difficult to identify sonographically, but with a little bit of practice, you can, in most cases, identify the medial head of the gastrocnemius here and the semimembranosus here. Bakers make M&Ms. And as very nicely demonstrated in this case, this cystic mass along the posteromedial aspect of the knee has a small tongue of tissue. A small portion of this mass is insinuating between these two tendons. Bakers make M&Ms. Before you can use the word Baker cyst, you need to document by MRI or sonographically extension of your posteromedial knee cystic mass between these two tendons as nicely identified here. And yet another nice example showing us in the posteromedial aspect of the knee, between the medial head of the gastrocnemius here, between the semimembranosus here, we have a cystic mass with a small sliver of this mass, a small portion of this mass extending between the medial head of the gastrocnemius and the semimembranosus. Bakers make M&Ms. And on Doppler interrogation, as you might expect, this Baker cyst, given its cystic nature, has no internal flow. Again, confirming that we're dealing with a simple cystic mass in this case. And yet a third example to wrap up our discussion. We have here in the posteromedial aspect of the knee, the medial head of the gastrocnemius, the semimembranosus, a simple cystic appearing mass in the posteromedial aspect of the knee with a tongue of tissue, a sliver of this cystic mass insinuating into the region of the semimembranosus gastrocnemius bursa between these two named tendons, with the MRI nicely reinforcing the anatomy here. This cystic mass is posteromedial and located between the medial head of the gastrocnemius and the semimembranosus tendons. Bakers make M&Ms. What are some potential complications of Baker's cysts that we need to be aware of? Most are asymptomatic and identified incidentally. Many, when they become larger, can be painful. And one of the most feared complications of Baker's cysts as they become larger is the potential to cause mass effect on the adjacent neurovascular structures. In particular here, we see a Baker's cyst that is adjacent to the popliteal vessels. Mass effect on the popliteal vein, for example, can predispose to deep DVT formation. And here is a nice example that I had just from last week, where this was initially called a Baker's cyst, but the sonographic images that I was provided to interpret didn't demonstrate well the communication into the region of the semimembranosus gastrocnemius bursa. None of this complex posterior knee mass extended between those two tendons. And so I was reluctant to call it a Baker's cyst. And indeed, this ended up being a hematoma due to prior trauma, completely separate anatomically from the region of the semimembranosus gastrocnemius bursa. Teaching point: not all masses in the back of the knee are popliteal cysts. We should only use the word Baker's cyst or popliteal cyst if we can identify that sliver of tissue, that tongue of tissue extending between the semimembranosus and gastrocnemius muscles. And so, when would we consider aspirating a Baker's cyst using sonographic guidance, for example? Not frequently. I get asked to do this a lot, and most of the time I say no. And the reason is that very frequently these recur. Because as I mentioned, it's not, the pathology is often not due to an issue of the cyst itself, but due to a primary knee issue. And so aspirating the cyst is only going to provide temporary pain relief, and that cyst will oftentimes recur. You can consider aspirating it if it's very large and the patient's knee pain is predominantly posterior in the region of the cyst. If perhaps it's causing mass effect on the popliteal vein, which might predispose to DVT formation. Consider a joint injection instead to treat the primary knee pathology that might limit popliteal cyst formation in the first place. And of course, during your sonographic intervention, we want to be aware, cognizant of the anatomic location of the adjacent neurovascular structures. Okay, now to perhaps a slightly less common area of the knee where we see bursal inflammation, the anterior aspect of the knee. And I have lots of fun pictures to show you of three different anterior knee bursa that can be inflamed. We have our prepatellar bursa that hangs out anterior to the patella and the proximal patellar tendon. We have our superficial infrapatellar bursa that lives superficial to the distal patellar tendon. And finally, we have our deep infrapatellar bursa that lives deep to the distal patellar tendon, with a nice sort of clinical image of prepatellar bursitis to introduce this subtopic. And so we make our way first to the MRI and the radiograph to provide you with a high-level anatomic understanding of where these bursa exist. Here we have two radiographic images with superficial infrapatellar bursitis. Notice the soft tissue swelling is along the anterior inferior aspect of the knee, superficial to the distal patellar tendon. And a nice MRI example. Again, I want you to be oriented anatomically, comfortable with the anatomy of these bursae. We have, again, our patella here with our patellar tendon coming down to attach to the tibial tuberosity with a soft tissue mass in the subcutaneous soft tissues, superficial to the distal patellar tendon. We know that this is the anatomic location of the superficial infrapatellar bursa. And now we have the pleasure of seeing a series of sonographic images of the superficial infrapatellar bursa. Let's get oriented anatomically. The patellar tendon is this fibrillar band-like structure here that comes down to attach to the tibial tuberosity here. Right where you expect the superficial infrapatellar bursa to be, you have a complex mass. Notice this mass is mainly solid with some small cystic components, and it even has internal flow on the color Doppler image. This mass put anywhere else in the body away from an area of a known named anatomic bursa would be very suspicious and certainly would require further investigation to rule out more concerning pathology like malignancy, for example. But if we know our anatomy, if we're comfortable with our anatomy, and we've recognized that this location, superficial to the distal patellar tendon, is an area of a known named anatomic bursa, then we should consider bursitis for this particular case. Another nice example. Notice where the soft tissue swelling is, anterior to the distal patellar tendon. Notice where this, again, complex, predominantly solid appearing mass is located, superficial to the distal patellar tendon. Here's our patellar tendon coming down to attach to the tibial tuberosity, and we have our mass superficial to the distal patellar tendon. This particular complex appearing mass, with both solid and cystic sonographic components, does not have significantly increased internal flow, perhaps suggesting that this bursal inflammation is more chronic and long-standing without active bursal inflammation present. Yet another nice example of superficial infrapatellar bursitis. Let's go over the anatomy. Here's our band-like patellar tendon coming down to attach to the tibial tuberosity. We have a complex mass in the soft tissue superficial to the distal patellar tendon with both solid and cystic components. Again, we need to be aware that there is a named bursa in this area, the superficial infrapatellar bursa, which triggers our understanding that this mass, this complex mass, may very well be bursitis rather than something more concerning like a soft tissue sarcoma. And my last example of superficial infrapatellar bursitis, going over the anatomy, here's our patellar tendon, band-like structure coming down to insert onto the tibial tuberosity with another complex soft tissue mass, superficial to the distal patellar tendon, in the exact location, in the expected location of the named superficial infrapatellar bursa. This complex soft tissue mass as well does not have significant internal flow, which may suggest to us that this is long-standing chronic indolent bursitis without active inflammation. And now let's review another bursa close to the superficial infrapatellar bursa, but this time deep to the patellar tendon. Notice our patella is here, with our patellar tendon coming down to attach to the tibial tuberosity here. And we have a soft tissue mass in the location of the named deep infrapatellar bursa. Patellar tendon here with a peripherally enhancing soft tissue mass in the region of the named deep infrapatellar bursa. Again, to provide you with a high-level anatomic understanding of where we are, we're not in the area of the prepatellar bursa number 1. We're not in the area of the superficial infrapatellar bursa number 2. We're in the area of the deep infrapatellar bursa, number 3. This one ended up being infection of the bursa, a fungal infection in particular with cocci. Sonographically, we have some beautiful images in this patient. We have our patellar tendon here. We have our tibial tuberosity more inferiorly. And of course, we have our fibrillar patellar tendon going from one to the other. Just where you would expect the deep infrapatellar bursa to be, deep to the distal patellar tendon, we have again a complex, predominantly solid appearing soft tissue mass without significant internal flow. A bonus finding in this case would be a focal area of prepatellar bursitis as well, demonstrated by this mass superficial to the proximal aspect of the patellar tendon. The prepatellar bursa, as I have alluded to many times, is more proximal and lives either anterior to the patella or anterior to the proximal aspect of the patellar tendon. Number 1. Let's review our sonographic anatomy. Here's the patella here. Here's the tibial tuberosity here. We have our patellar tendon coursing from one bone to the other. Anterior to the patella and proximal patellar tendon, we have here a simple, mostly simple appearing cystic mass with some internal septations. Again, the key here is to recognize that there's a known named anatomic bursa in this area. Anatomy is key to making the diagnosis, because as you've seen, this, the sonographic, the imaging appearance of bursal inflammation can range from a very simple appearing cystic mass to a very complex solid appearing mass. So we can't rely on the intrinsic imaging appearance predominantly. We need to rely mainly on the anatomic location. Here's a great set of radiographs, again demonstrating prepatellar bursitis. Notice left anterior knee soft tissue swelling on these sunrise views. That's absent on the right side. With the corresponding sonographic image, the patella is here. The tibial tuberosity is here. The patellar tendon is this band-like structure going from one bone to the other. And anterior to the proximal patellar tendon, in the area of the named prepatellar bursa, we have again this complex soft tissue mass with both solid and cystic components. Recognize that there's a named anatomic bursa in that area, the prepatellar bursa. All right, well, let's jump to the hip. This is a bursa that's really helpful to know about because in my experience, if you're not familiar with this particular bursa, it's very frequently misinterpreted as something more ominous, a soft tissue sarcoma, for example. What bursa am I referring to? Well, our friend, the iliopsoas bursa. The iliopsoas bursa occurs, as you can see nicely demonstrated on this right hip CT, along the anterior aspect of the hip joint. And in particular, it's intimately associated with this round density here, the iliopsoas tendon. You'll see it very commonly anterior and medial to the iliopsoas tendon. Pathologically, we know that this bursa can certainly occur from acute and or chronic repetitive injury to the soft tissues of the anterior hip, or may be a manifestation of primary hip pathology, as a segment of the population has communication between this bursa and the hip joint. So osteoarthritis, inflammatory arthritis of the hip joint can result in distension of the iliopsoas bursa. And again, really important to know the anatomic location of these named bursae, because if you don't, you can easily misinterpret them for something scarier, like the iliopsoas bursa is often misinterpreted as. Let's jump to the ultrasound imaging. The iliopsoas bursa is going to be located, as we mentioned, anterior and medial to the iliopsoas tendon. And here we see the iliopsoas tendon as this echogenic structure sonographically, as all tendons should be sonographically. In this patient without iliopsoas bursitis, we see no mass in the expected location of the iliopsoas bursa. However, when we jump to this transverse sonographic image of the anterior hip, we see in its expected anatomic location a cystic mass representing the iliopsoas bursa, anterior and medial to the echogenic iliopsoas tendon, our anatomic landmark for the iliopsoas bursa. Again, I just want to juxtapose the CT and the ultrasound to reinforce the anatomy. We're in the anterior aspect of the hip. We're looking to identify the iliopsoas tendon, and we're looking anterior and medial to the iliopsoas tendon. That's the expected location of the named iliopsoas bursa. You see a cystic looking mass in that area, you see any mass in that area. Consider iliopsoas bursitis as part of your differential diagnosis. Another nice example I had from just the other day, a smaller example of iliopsoas bursitis, but still the anatomy is well demonstrated. The echogenic round structure is the iliopsoas tendon. This small cystic appearing mass, anterior and medial to the echogenic iliopsoas tendon, is a small iliopsoas bursa that on color Doppler interrogation has no internal flow, confirming the cystic nature of the mass. And finally, to wrap up our lower extremity discussion, we're going to talk about the retrocalcaneal bursa. Where's the retrocalcaneal bursa located? Well, it's located in this little crevice between the Achilles tendon and the calcaneus, pointed to by our red arrow with a small region of increased fluid signal in that area. Again, the common theme extends to this particular bursa: acute trauma, chronic repetitive trauma, primary inflammatory process that can affect the bursae, like rheumatoid. We also want to think about enthesopathy as a possible cause of bursal inflammation, especially when we're dealing with these bursae that exists at sites of ligamentous and or tendinous attachment to bone. We're all aware that enthesopathy is one of the chief musculoskeletal manifestations of the seronegative spondyloarthropathies. Patients with ankylosing spondylitis, reactive arthritis, psoriatic arthritis, in addition to the arthritic manifestations of those inflammatory arthritides, they often cause inflammation anywhere a tendon and or ligament attaches to bone, aka enthesopathy. This inflammation at sites of ligamentous and or tendinous attachments to bone can extend into the adjacent bursa, as in this patient with ankylosing spondylitis, who had really severe enthesopathy in the hindfoot, resulting in Achilles tendinopathy, retrocalcaneal bursitis, and even erosion of the calcaneus. Let's look, for the sake of for the sake of reinforcing the anatomy, what the normal hindfoot should look like on MRI. Notice in a patient without retrocalcaneal bursitis, there's no fluid signal, there's no inflammation, there's no abnormality at the junction between the Achilles and the calcaneus. Notice the anatomic location of the retrocalcaneal bursa between the Achilles and the calcaneus. Here's another nice example on MRI, juxtaposed to a normal ankle MRI. There's an area of fluid signal here, a small cystic mass. What are we going to call it? Well, because we know that there's a named that there's a named bursa in this area at the junction of the Achilles and the calcaneus, we're going to call this retrocalcaneal bursitis because we know our anatomy. What does it look like sonographically? Now that we have a high-level understanding of where this bursa lives based on MRI, let's drill down to the ultrasound. right where you expect to see this bursa. On MRI, we see it in the same location sonographically. Here's our fibrillar band-like Achilles tendon coming down to attach to the calcaneus. At the junction between these two structures, we see distension of the retrocalcaneal bursa. Then on Doppler interrogation, in this particular patient does not have increased flow, perhaps suggesting more chronic, long-standing, indolent bursal inflammation rather than an acute bursal inflammation. And again, I want to compare and contrast the MRI with the ultrasound because I really want you to be comfortable with the anatomy. The retrocalcaneal bursa in this patient with rheumatoid arthritis is distended at the junction of the Achilles tendon and the calcaneus, at the junction of the Achilles tendon and the calcaneus. And here's another case with perhaps just a physiologic, tiny amount of fluid in the retrocalcaneal bursa. Just wanted to show you yet another example of anatomically where this bursa lives, at the junction of the Achilles tendon and the calcaneus, right in this area. Anatomy is key. Wonderful. Okay, let's jump to the upper extremity. Olecranon bursitis, posterior aspect of the elbow. Again, all the pathologic processes for all of these bursa, very similar. Acute trauma, you fall on your elbow. Chronic repetitive trauma, you have a job that requires that you're working on your hands and knees with lots of chronic repetitive stress to the elbow areas. Acute bursal infection, or a primary inflammatory process involving the bursa. And we've all been taught that the two systemic inflammatory processes that love to cause olecranon bursitis, of course, are rheumatoid arthritis and gout. Recall that the triceps tendon also attaches to the olecranon near the area of the olecranon bursitis. And so enthesopathy, vis-a-vis our discussion we had with the retrocalcaneal bursa, is also up for grabs. Let's look at some radiographs to establish the anatomy. The olecranon bursa, posterior elbow. Notice what the posterior elbow soft tissues are supposed to look like normally. Notice this patient with olecranon bursitis due to RA has significant posterior elbow soft tissue swelling. Another patient with rheumatoid, notice the normal width of the olecranon posterior elbow soft tissues. Notice the significant posterior elbow soft tissue swelling in a patient with olecranon bursitis and rheumatoid. Notice in this patient with gout, the normal thickness of the olecranon bursa area compared to this patient with severe olecranon bursitis due to gout. Again, the teaching point, the most common systemic inflammatory processes that result in olecranon bursitis are going to be gout and rheumatoid arthritis. Some great MRI images of the posterior elbow. Normal posterior elbow compared to these two patients, one with rheumatoid arthritis, one with gout, both with relatively large posterior elbow masses that, especially in this case, in this patient with gout, look very scary, very heterogeneous, certainly not simple and cystic. Put these masses anywhere else in the body, outside the location of a known named anatomic bursa, we would be concerned about more ominous diagnoses. But because we know that there is a named anatomic bursa in this area, and if we have a patient with gout or rheumatoid, and we recognize that patients with gout and rheumatoid frequently have olecranon bursitis, we can consider olecranon bursitis in our differential diagnosis. And here's a nice clinical image juxtaposed with the MRI, highlighting the anatomy. I'm doing my best to reinforce the anatomy with these cases. You can see this nice example on this fluid-sensitive MRI with distension of the olecranon bursa posterior to the olecranon. Sonographically, now that we've got the anatomy worked out, sonographically, what does olecranon bursitis look like? Well, we can see here the triceps tendon T coming down to attach to the olecranon, this bony structure here, with posterior elbow soft tissue swelling in the area, in the region of the known named olecranon bursa. Here we see it in both longitudinal and transverse imaging. Anatomy is key. Soft tissue swelling in the area of the posterior elbow, olecranon bursitis. Since we're talking about the elbow, let's discuss another bursa that's important to know about. The bicipital radial bursa that lives not near the proximal biceps tendon at the shoulder, but at the distal biceps tendon at the anterior elbow. Again, the mechanism of bursitis here is the same song and dance: acute injury, chronic repetitive injury, a primary synovial inflammatory process. Here's an MRI. Again, we want to be cognizant of the surrounding anatomy, because knowing the anatomy is going to lead to consideration of bursitis in the differential. Notice this band-like black structure here. That is your distal biceps tendon coming down to attach to the radial tuberosity. The surrounding fluid signal is bicipital radial bursitis. This round structure is your biceps tendon going down to attach to the radial tuberosity. This cystic mass surrounding the distal biceps tendon at the anterior aspect of the elbow is your bicipital radial bursitis. Sonographically, what does this look like? Well, here's a nice example of a normal distal biceps tendon. Just like every other tendon in the body, sonographically, it's a band-like, linear, fibrillar structure. Compare that to a patient with bicipital radial bursitis. The biceps tendon here, which is sonographically slightly out of plane, that I've labeled B for you, is surrounded by this hypoechoic or anechoic fluid that you certainly don't see in this normal case. No fluid surrounding this biceps tendon, no cystic mass surrounding this biceps tendon. This cystic mass, this fluid, we should consider bicipital radial bursitis because of its location surrounding the distal biceps tendon. Here's a patient that had biceps tendinopathy, as manifest sonographically by a thickened hypoechoic distal biceps tendon. But still, the surrounding soft tissues are normal. We don't see what we see in this case, with this cystic hypoechoic mass surrounding the distal biceps tendon. Bicipital radial bursitis. Bicipital radial bursitis is not inflammation of the tendon, it's inflammation of the bursa that lives adjacent to the distal biceps tendon. This knowledge of anatomy was very useful to me when presented with this large, painful, and very scary looking anterior elbow soft tissue mass sonographically. Notice the calipers are outlining this predominantly solid appearing soft tissue mass along the anterior aspect of the elbow that in fact has increased internal flow on Doppler interrogation in this patient with both rheumatoid arthritis and known malignancy. With the feared complication, the feared question being, is this metastatic disease? Well, we can see that this is another very nice example of a severe example of bicipital radial bursitis. Notice this large heterogeneous soft tissue mass along the anterior aspect of the elbow. It's not the mass, it's not the appearance of the mass that makes the diagnosis, but its location. Notice where it is, surrounding this band-like hypointense structure, the biceps tendon. Here it is on axial imaging, and you can see this complex soft tissue mass is intimately associated, is circumferentially surrounding the distal biceps tendon. This was another example of severe bicipital radial bursitis in a patient with rheumatoid arthritis. Would have never thought of that diagnosis unless we considered the anatomic location adjacent to the distal biceps tendon. And finally, our last upper extremity topic, probably the most common bursa that I interact with, that most of us interact with on a regular basis, the subacromial subdeltoid bursa in the shoulder. Where is the subacromial subdeltoid bursa? Well, again, let's dive deep into our anatomy. Here we have a coronal fat-sensitive MR image showing the acromion here and the deltoid here. Acromion here, deltoid here. And as you would expect, the subacromial subdeltoid bursa, as indicated by these stars, is going to be deep to the acromion, deep to the deltoid. What's the most common reason to have subacromial subdeltoid bursitis? Well, our bread and butter external impingement. The rotator cuff and the adjacent subacromial bursa get impinged between the osseous structures of the coracoacromial arch and the humeral head, causing bursitis due to chronic repetitive friction-related injury. As you know, subacromial bursitis is often seen in conjunction with rotator cuff pathology, but certainly we have many examples of primary bursal pathology due to a rheumatologic disorder, crystal deposition disease, and of course, given the location of this bursa in an area where a tendon is attaching to bone, consider enthesopathy in the context of a seronegative spondyloarthropathy. What does this bursa look like sonographically? Well, let's go through in the anatomy. I have one longitudinal sonographic image for you without labels and one with. The key anatomy here that we're going to repeat time and time again is in sequence from superficial to deep. First the deltoid, then the rotator cuff with the classic bird beak appearance here, and then the greater tuberosity. Where's the subacromial subdeltoid bursa? Of course, deep to the deltoid, as you can see here, indicated by the stars. Of course, in someone without bursitis in this area, the subacromial subdeltoid bursa is a potential space. It's not visible. It's not sonographically visualized. In transverse sonographic image, the same anatomic relationships are preserved. The deltoid, the rotator cuff, the greater tuberosity. The deltoid, the rotator cuff, the greater tuberosity. Where's the bursa located? Deep to the acromion, deep to the deltoid, right in the area where these stars are, a potential space in someone without frank bursitis. You can't see it. Again, I want to reinforce the anatomy. Deep to the acromion, deep to the deltoid, lives our friend, the subacromial subdeltoid bursa. Sonographically, deep to the deltoid, superficial to the rotator cuff, lives the subacromial subdeltoid bursa. Here's a very nice example of subacromial bursitis I had from about a month ago in a patient with active, relatively severe rheumatoid arthritis. Where is the bursa supposed to be? Deep to the deltoid. In this patient, there's nothing deep to the deltoid. In this patient, we see this relatively severe distension of the subacromial subdeltoid bursa with this heterogeneous, predominantly solid appearing bursitis, which presumably represents frank synovitis in a patient with subacromial subdeltoid bursitis due to rheumatoid. Another patient with rheumatoid arthritis, where is the subacromial bursa? Deep to the deltoid, superficial to the cuff. In this patient, exactly where we expect to see the subacromial bursa, we see bursal distension. Deep to the deltoid, superficial to the cuff. Deep to the deltoid, superficial to the rotator cuff. in a patient with rheumatoid arthritis, with a really nice MRI proving to us that this patient indeed has pretty severe subacromial bursitis due to his rheumatoid. We can see distension of the subacromial bursa with significant near circumferential bursal enhancement in this patient with rheumatoid arthritis. Sonographically, deep to the deltoid, superficial to the cuff. Ultrasound guided bursal injection, certainly something I do frequently for patients with external impingement and resultant symptomatic subacromial bursitis. Notice my needle entering the expected location of this potential space, where deep to the deltoid, superficial to the rotator cuff, right along this plane. Deep to the deltoid, superficial to the rotator cuff. And after I inject my steroid and anesthetic, you can see distension of the subacromial subdeltoid bursa, deep to the deltoid, superficial to the rotator cuff. Another disease process that commonly results in secondary subacromial bursitis that I see all the time is this crystal deposition disease, colloquially referred to as calcific tendinosis, but the crystals that cause calcific tendinosis are of the hydroxyapatite variety. So hydroxyapatite deposition disease, as you can see here radiographically, as these calcifications projecting over the soft tissues of the lateral shoulder, is seen very well sonographically as these echogenic structures within the supraspinatus tendon. You can see that in this patient, in the area of the subacromial bursa, we don't see obvious manifestations of bursitis. Where is the subacromial bursa? Right in this plane, deep to the deltoid, superficial to the cuff. Now, where else might hydroxyapatite deposition disease rear its ugly head? Well, sometimes you get bursal inflammation because of hydroxyapatite crystals in the cuff, but sometimes you get bursal inflammation because the hydroxyapatite crystals are in the bursa itself, causing not calcific tendinosis, but calcific bursitis. Let's look at an example. Remember the normal anatomy in this area. The subacromial subdeltoid bursa is here, deep to the deltoid, superficial to the cuff. Let's look at this patient with subacromial calcific bursitis. Here's the deltoid here. Here's the supraspinatus here that looks irregular and hypoechoic, largely due to anisotropy. But what do we see in this interval? Deep to the deltoid, superficial to the cuff, but these echogenic shadowing structures, which turn out to be hydroxyapatite crystals, not in the cuff, but in the adjacent subacromial bursa. I've put little stars here for you so you can see these gallstone-looking structures hanging out in the subacromial bursa. And on MR imaging, this patient had severe subacromial bursal inflammation adjacent to these to this crystal deposition disease. So I thank you so much for your time, and I remind you that these bursa, they're fun, they're everywhere, but you can't rely on the sonographic appearance. They can be solid looking, they can be cystic looking. You really got to know your anatomy so that you don't forget to think about bursitis and not misinterpret these guys as something scarier. Thank you so much.
Thank you so much, Dr. Salibian. Do you want to go ahead and launch some poll questions?
We do have some questions for you guys.
All right. First one is on your screen. Which two muscles does a popliteal cyst extend between? Everyone should see it on their screens. We have about 40% people answered, so give another couple of seconds. Okay. Right, here are the results, if you would like to comment.
Great. I hope you all, it seems like most of you remembered that bakers make M&Ms, medial head of the gastrocnemius and semi-membranosus.
All right. Next question.
This is a good one that we didn't necessarily discuss, but certainly a very helpful troubleshooting tool if you're worried about the presence of hydroxyapatite crystals in your cuff or in your bursa. What is the easiest, cheapest way to confirm the presence of hydroxyapatite crystals?
Right, about 50% answers, so I'll give another 10 seconds to respond. All right, here we are. Here are the results.
Excellent. And again, I think the majority got it. As I showed you a couple of examples of hydroxyapatite crystal deposition disease is very easy to see and identify radiographically. The X-ray is cheap, it's ubiquitously available, and will be a very helpful adjunctive tool when you think you might see these echogenic crystals on ultrasound. Challenging sometimes to see them on ultrasound, very easy to see radiographically. Get that quick X-ray as a problem-solving tool.
Right, number 3. It's going to be interesting. It's very close. There are 2 answers, very close to each other. Okay, about 50% people answered, so another couple of seconds. Okay, here are the results.
Great. And, you know, this question was just to remind you that of the phenomenon of enthesopathy, which is a, key musculoskeletal manifestation of the seronegative spondyloarthropathies, of which ankylosing spondylitis is the archetypal disease process.
Great. I have one more question. Just to see if you guys will be able to apply what you learned today from the session. So if you would like to answer that, I'll leave the poll open and we'll move into the Q&A. So the first question is, any experience with scapulothoracic interval bursitis?
So, you know, what's really good about ultrasound is its ability to see these superficial structures. When you get to the deeper anatomic areas, especially those that are close to several different osseous structures, the ribs, the scapula, for example, it is challenging to see the inflamed bursa for sure. And I would say, secondly, as that not being a very common cause of bursitis, I feel as though sonographically, perhaps, ultrasound is not the best tool to evaluate for that type of bursitis. I would go for ultrasound, for MRI to evaluate for inflammation in the region of that named bursa.
Okay, thank you. Next question is, how can you differentiate bursitis from synovitis via sonography?
So it's an interesting question that requires, I think, a little bit of clarification. As you can see on, I don't know if you guys can still see the images behind you, but bursitis is an all-encompassing term that includes bursal distension with simple fluid, all the way to much more complex bursal inflammation with synovitis. So it's a spectrum. So, and the way you distinguish between simple bursal distension and synovitis is by looking at the sonographic appearance of the distended bursa. If the bursa is distended with anechoic or hypoechoic material, then that suggests a more reactive, simple bursitis. If the bursa is distended with solid appearing echogenic material, that is more suggestive of solid material, like synovitis.
Great. Thank you so much. And I have one more question, last one. What is the needle pattern you use to aspirate knee bursitis? And then metastasis and hematoma, how to separate?
So what's great about these anterior knee bursas that we spent a lot of time talking about, they're all very, very superficial. And oftentimes you don't even need image guidance. Where image guidance is very helpful, specifically with ultrasound, is if you have a bursa that has different components. Let's say an area that's more solid due to synovitis and an area that's more simple appearing and composed of fluid. Certainly you'd want to put your needle in an area that is more fluid-like so that you can actually aspirate something if you're doing it for a diagnostic purpose. And there really isn't a specific approach. I just put the ultrasound probe on, look at the area that looks more cystic, that I think I have a better chance of getting some fluid out of, and direct my needle into that area. That's the great thing about those anterior knee bursae in particular. There are no important structures, no important nerves or blood vessels or other structures in that area that you really need to contend with.
All right, I just got 2 more questions submitted. How can we differentiate between bicipar? Okay, I'm sorry, I may not be able to pronounce all of this, so I'll just copy paste for you. Can you see the questions, Dr. Salibian, in the Q&A box?
Let me see if I can click on here.
All right, I'll try my best.
Sorry, I'm having a little trouble. Let me see if I can. Oh, here we go. So how can we differentiate between bicipital radial bursitis and tenosynovitis, so the distal biceps tendon? Was that one of the questions?
Yes, that's the one.
Oh, great. Okay. So I think practically speaking, perhaps we don't need to, because the pathophysiology that results in both of those disease processes is very, very similar. Acute injury, chronic repetitive injury, and inflammatory arthritis is going to lead to both tenosynovitis and bicipital radial bursitis. Perhaps one helpful differentiating feature may be the configuration of the fluid around the biceps tendon. If it's more linear and more closely parallels the course of the biceps tendon, perhaps that's tenosynovitis, whereas a more bulky mass-like area of inflammation would be more suggestive of bursitis, like the example that I showed you in the patient with rheumatoid and history of malignancy.
Okay, great, thank you. Next one is, can you comment on intralesional steroid injection as treatment after aspiration?
Yeah, I mean, certainly with all of these bursae, there's the standard of care for managing them and making sure they go away appropriately, that they resolved. I have certainly been asked to do steroid injections into these bursa, especially those that are, refractory to the more conservative medical management. But I feel like most of them, with the appropriate conservative therapy, go away on their own.
Great. I think that's all we have. We are at time. This webinar was recorded and will be available on our website next week. I would say check back on Wednesday. You will also receive an email with the recording instructions. And then thank you so much for joining us today. Also, thank you so much, Dr. Salibian, for taking the time and going over this helpful information. We also encourage you to register for POCUS World Conference that will be in September. Many more topics will be discussed during the event, and then hopefully you'll be able to join us then in September. Again, thank you so much for joining us. Have a wonderful day. We'll see you in our next webinar, which will be in October. So thank you so much. Have a wonderful day.
Thanks, everybody.
Thank you.